Here we present a PowerPoint presentation of a general surgical techniques. This is Dr. Yash Gandhi, Junior Resident from Department of ENT. In this presentation, we'll cover certain points such as surgical tray and key points related to that, suture materials, suture needle types, suturing techniques and distinct approaches according to sites in ENT. Surgical tray. First of all, the basic instruments which are included in a surgical tray comprise a scalpel, a needle driver or what we say a needle holder, forceps both toothed and non-toothed, skin hook, tissue cutting and suture cutting scissors, gauze, preferably a non-woven gauze due to its excellent wicking property and it does not tend to unravel, so preventing any foreign body deposition while closure. Sometimes an electrocautery may also be needed. Basically, the make of surgical instruments most commonly comprise stainless steel and may include inserts of tungsten carbide, that is to increase their longevity. The types of needle holders include Webster, Halsey, Krylewood or Debacki, Mayo Hagar. These are the common types of needle holders. Of course, there are various other types too. The basic differences between the three most commonly used needle drivers are, as in Webster's needle driver, both the jaws are smooth, whereas in Halsey's needle driver, one of the sides is smooth, the other one is serrated. In Krylewood or Debacki's needle holder, the jaw is serrated while having a groove in between. There are various grasps for as to how to hold the needle drivers. The basic needle driver grasping position is with a thumb and the ring finger in both the rings. It has an advantage that it is easy to open and close the driver. But the major disadvantage is that movements are restricted to the range of wrist movements. This is one of the common default positions for many surgeons, palming the needle driver. That is, one of the rings has ring finger resting in it slightly, while the other one is empty. The third one is palming the entire needle driver with no fingers in the rings. It has excellent range of movements but needs training to open and close the driver with ease while closure. Now grasping the suture needle. Basically a suture needle has these parts as the first is point, the next is body and the swage or what we call commonly as an eye. The needle holder is supposed to be grasped at the junction of anterior 2/3 and posterior 1/3 of the needle. But in certain spaces like in tight spaces or while we are cutting through dense tissue, we need to hold it or grasp it a bit anteriorly. Now the suture materials, which are commonly divided into monofilament and multifilament based on the structure of threads used, absorbable and non-absorbable based on the characteristic of the material used, natural and synthetic based on the origin of the material used. We'll describe it in details now. The basic classification is absorbable and non-absorbable, which we commonly use. Absorbable has further examples like Vicryl, plain catgut, chromic catgut, Dexon, polydiaxanon or PDS. Those are two types, PDS1 and PDS2. Then collagen, Maxon and monocryl. Whereas on the other hand, non-absorbable sutures consist of silk, nylon or the famous brand name Ethylon, mercilene, proline that is polypropylene, steel or aluminum wire and staples. There are multiple metallic suture materials like tantalum, gold, silver, aluminum. Absorbable synthetic materials. These most commonly used is Vicryl, that is polyglactin 910. It is more commonly available in purple color, which is round bodied, whereas Usually the non-dyed vicryl comes with a cutting edge. It is a copolymer of lactide and glycolide. It has minimal tissue reaction, braided, coated suture material that retains its strength for approximately 3 weeks and is completely absorbed in less than 3 months. It is usually used in general soft tissue approximation, as we call it the soft tissue closure, and in vessel ligation. There are few newer variants of this vicryl. They include vicryl rapide. It has a strength till 2 weeks, that is, it absorbs very quickly, and antibacterial coated vicryl. Next is monocryl, that is polyglycapron, a monofilament alternative to vicryl. It loses its strength in less than 1 month, though complete absorption takes 3 to 4 months. It is a bit more expensive than vicryl, and it also has a newer variant, that is antibacterial coated monocryl. PDS, polydiaxanon. PDS1 and PDS2 are very long lasting monofilament absorbable sutures. PDS2 came out later than PDS1. There is a controversy whether which one of is better, but PDS2 is more commonly used nowadays. Useful when long-term strength retention is critical. It retains its strength for an extended period of time, that is, with 50% strength retention at 5 weeks, and may take more than 6 months to absorb. Now, the absorbable natural suture materials, they comprise plain catgut as well as chromic catgut. Plain catgut, it is lighter yellow to brown in color, derived from bovine or sheep intestines, breaks down by enzymatic degradation rather than the hydrolysis, which is the common breakdown method used in synthetic absorbable sutures. 50% strength lost by 7 days and complete absorption by 70 days. Chromic catgut is a longer lasting version of plain catgut. It is colored brown with pyrogallol dye. It is treated with chromium salt. Now, we usually have seen chromic catgut. While we open it, it comes in a solution that comprises of isopropyl alcohol and water. As chromic catgut, when it comes in contact with air, it becomes stiff and it breaks off easily. So it is packed in a solution to preserve the suture material. Distinctly, it is used in the presence of infection in OBGYN surgeries, cardiovascular, and neurosurgeries. It has 50% strength, which gets lost by 10 days, and complete absorption by 84 days. Now we'll throw some light on non-absorbable synthetic materials. First of all, we'll come across nylon, which comes in braided as well as monofilament material. Polyamide polymer suture, and it has a good memory. Nylon comes in white, black, or green in color. It elicits minimal tissue reaction. The monofilament version of nylon is very smooth in tying, so it is more commonly used. It is pliable when moist. Pre-moistened form of nylon is used in cosmetic plastic surgery. It is useful for most skin closures. It has high tensile strength, 81% of which is retained at 1 year and 66% at 11 years. The next one is polypropylene or Prolene. It is a minimally reactive suture that has the ability to move very smoothly through the tissues. It is a monofilament suture having good memory. It is more plastic, so a bit slightly challenging to handle as compared to nylon. It is a good option for non-absorbable subcuticular suturing in particular. It has high tensile strength, so preferred in areas where long-term strength retention is needed, like holding open of a stoma as in laryngectomy surgeries or vascular anastomosis, etc. It has an innate property of resistance to infection. Now we'll see a non-absorbable natural suture material, that is surgical silk. It comes in braided nature, black in color, and it is derived from cocoon of a silkworm larvae. It has a significant tissue reaction, that is inflammatory reaction. It undergoes proteolysis as degradation process and is undetected by 2 years. Its natural softness makes it useful in repair of tendons where synthetic suture has a tendency to poke against the delicate tissues. Now, what is a monofilament suture? Monofilament sutures, when cut, grossly appear as a single strand of suture material as all fibers run parallel to each other. It has minimal tissue trauma and ties a bit smoothly. It resists harboring microorganisms. It requires more knots than a multifilament suture, that is a major disadvantage. Examples include monocryl and PDS, which are absorbable sutures, whereas proline and nylon, which are non-absorbable ones. Now, what is a multifilament suture? In a multifilament suture, when cut in a cross section, we can see fibers which will be twisted or braided, so they grossly appear as a multi-stranded material. It provides good handling and a major advantage that fewer knots are required in tying. Greater resistance is encountered in tissues, so not fairly smooth as compared to monofilament sutures. Examples: vicryl and catgut, which are absorbable ones, and silk, that is a non-absorbable suture. These are certain important points in suture degradation method. Suture material, that is catgut, which is absorbable natural source of suture material. Method of absorption in these types are proteolytic enzymatic digestive process, whereas in vicryl and PDS, which are absorbable but synthetic materials, they undergo hydrolysis. Vicryl undergoes hydrolysis and PDS undergoes a bit slow hydrolysis. Now the non-absorbable one, patented silk and nylon, go under gradual encapsulation by fibrous connective tissue. These are various suture needle types. For one is taper point and what we commonly call round bodied. It is suited to soft tissue. It dilates the tissue rather than cutting it. Then comes conventional cutting, which on cross section appears as a standing equilateral triangle. It is very sharp. It cuts rather than dilates the tissue. It creates weakness along the suture tear out. So these materials can be a bit gruesome when tying in the skin because it can cut through very easily. Reverse cutting, which on cross section appears as an inverted triangle. These are also very sharp but very ideal for skin. It cuts rather than dilates, same as conventional. Then there is a taper cutting material. It is ideal in tough or calcified tissues. It is mainly used in cardiac and vascular procedures. Now we'll look over a topic: suturing techniques. Basically, suturing techniques are broadly classified into following categories like simple sutures, mattress sutures, and subcuticular ones. Simple sutures. The simple sutures can be simple interrupted or simple continuous sutures. Simple interrupted sutures, in this the needle is passed through both edges at an equal distance and equal depth from the incision and knot is tied. It is most commonly used suture type in general. It has an advantage that each stitch is independent and loosening of one of them will not produce loosening of the others. But the disadvantage is it is time consuming and each stitch is to be opened separately while removing. Simple continuous sutures, they can be interlocking as well as non-interlocking. It is rapid in tying and easy in removal, more commonly used in pediatric as well as it is used in closure of deeper structures like fascia, muscles, as well as in skin closures. It provides effective hemostasis and the tension is distributed evenly along its length. Now the mattress sutures, basically two types, vertical and horizontal. Vertical mattress suture has a fundamental that is far and near order of bites. The knot which we tie comes perpendicular to the wound edge. It is useful in wound eversion. It reduces dead space and minimizing tension across the wound. Now another version, that is horizontal mattress suture. There is no far near fundamental used in this suture. Bite from one side to opposite and back from opposite to same side as initial bite. The knot which we tie comes parallel to the wound edge. It is used distinctly for high tension wounds and wounds with fragile skin. These mattress sutures can be superficial, like when the knot is visualized externally, or they can be buried when knot is taken internally. Now the subcuticular sutures. This is an epidermal approximation technique which is suitable for wounds which are under minimal to no tension. This technique should almost never be employed in the absence of a deep dermal suture, since its strength is in fine-tuning epidermal approximation. So the basic prerequisite is we need to close the deeper layers first and then go for subcuticular suturing. Otherwise it is of no use. It is primarily an intradermal technique and therefore does not recruit any strength from the epidermis. So the presence of an intact and robust dermis is a prerequisite. This is a diagrammatic representation of a subcuticular suture. In this, the needle is passed from outside of the wound apex from a 2 to 5 mm distance, which is represented as a perpendicular line on the top of the diagram, to the interior of the wound, and needle is rotated superficially through the dermis on one side. This procedure is continued alternatingly on both sides and suture is taken in a running manner. At the end, after exiting the wound apex on the opposite side of entry, suture is tied over the top of the wound. Now we'll look over distinct suturing techniques used in ENT. Firstly, suturing techniques over forehead. There are various techniques used over forehead. First interesting one is dog ear tacking suture, which is a suturing technique used to prevent dog ear deformity, or what we call coning of skin or puckering of skin, while closing the everted edges in an elliptical incision or in flaps. Next one is purse string suture, which is more commonly used in puncture or circular wounds. Purse string suture has a disadvantage that it causes a puckering deformity. So it is used in areas where we anticipate that the puckering deformity is okay and it will resolve with time. The next one is setback dermal suture and buried vertical mattress suture. Both these sutures take into consideration the eversion of edges. Both these sutures have a fundamental that it has the bites are taken in dermis and exited through the same. They have good eversion of the wound margins, and the setback dermal suture is now considered superior in comparison to buried vertical mattress sutures, and setback dermal suture is a good option for budding surgeons to start with. The next interesting one is the tip stitch. This technique is designed to bring three ends of tissue together as in a V-shaped clean lacerated wound. This approach is conceptualized as a half-buried horizontal mattress suture too. It is used only when attempting to approximate three segments of a skin, and it is a niche technique also. Then there are multiple variants of setback dermal suture, such as pulley setback dermal suture. Then there comes the suspension suture. So basic suturing techniques over forehead are as described in the image. Next is suturing techniques over nose. The first one what we come across is a running diagonal mattress suture. It is a modification of running horizontal mattress suture. In this, the suture material comes across the wound in a diagonal pattern. This technique provides the benefit of decreased risk of tissue necrosis when compared with the running horizontal mattress technique, because the watershed area at risk for vascular compromise is smaller when the bites are taken at a diagonal uh, in a diagonal pattern rather than when they are perpendicular to the incision line. So it is done when there we anticipate or we require, in particular, wound eversion, like as over in the face region and in extremities. The next one is percutaneous setback dermal suture. This suturing technique uses the bite which goes straight from the epidermis to dermis and then comes out through subcutaneous tissue and on the opposite side. This technique is designed primarily for the closure of narrow wounds where there is insufficient laxity to permit the effective visualization of the undersurface of the undermined wound edge. So mostly used over the anatomical locations such as scalp, nose, lower leg, etc. Then there is percutaneous buried vertical mattress suture. The basic difference between percutaneous setback dermal and buried vertical mattress is that in setback dermal sutures, both the bites go throughout the width of the skin, whereas in percutaneous buried vertical mattress, one of the bite comes, the far end of the bite goes across the skin, whereas the near end comes between the epidermal and dermal layers. Then there are common simple running sutures, buried vertical mattress, setback dermal, and tip stitch, which we described in the previous slide. The three-dimensional complexity of the nose necessitates particular attention for surgeons. Various layers of tissue may require individual suturing and reconstruction, from cartilage to muscle to dermis. Non-absorbable 40, 50, or 60 suture material can be used. Nylon is preferred in such cases. Now, suturing techniques over and around lips. In lips, we are restricted and we have to look over the parts so that we do not cause any necrosis or any cosmetic deformities. Commonly used techniques are simple running suture, buried vertical mattress, simple interrupted one, and a tip stitch. Dog ear deformity near the vermilion border of the lip does not resolve properly and smoothly, so accurate reapproximation of the vermilion border is of critical importance in lip repairs and reconstructions. In general, 40, 50, or 60 absorbable suture material should be used on the lips, whereas non-absorbable material 40 or 50 can be used over the philtrum area. The suturing techniques over ear. As we all know, ear has a base of cartilage and over it is the skin. So we need to take care to prevent any perichondritis in such cases. In ear, usually simple running sutures, simple interrupted sutures are used. Certain areas such as in helical region, setback dermal sutures might be required. Then there is a particular Lambert suture and inverting horizontal mattress suture. In Lambert suture, we use the suture as we need to create a natural crease in certain anatomical locations. It is a niche technique designed to encourage wound edge inversion, whereas in all the previous cases where we saw, such as in vertical mattress sutures, setback dermal sutures, we needed wound edge eversion. In these cases, in such cases where wound edge inversion and natural crease is to be maintained, we use Lambert suture. It is primarily to create a natural crease. It may be used to recreate the LR creases as well as to better define the helical rim, and may also be useful when recreating the mental crease. So in the area of the ear where we require a natural crease, we should go more commonly for Lambert suturing technique. The ears, like the nose, have a complex three-dimensional array of ridges and valleys that must be respected if a reconstruction is to return to the appearance to normal. Tissue recruitment from the posterior ear, retroauricular sulcus, and mastoid allow for complex flap repairs on the helix and beyond. For transepidermal repair, non-absorbable 40 to 60 suture material can be used. Here also monofilament nylon is preferred. Now we'll discuss certain recent advances in suturing approach. Nowadays staples are used which are made up of high quality stainless steel. These are strictly for skin closure. Major advantage is it is significantly less time consuming. and very easy to remove. Adhesives such as N-butyl cyanoacrylate, sterile liquid used as a topical skin adhesive. It reacts with moisture of skin surface to form a strong but flexible bond. It is preferably used only for skin edges approximation. Now tapes or the patented name Steri-Strips from 3M. It is a use of tissue adhesive adjunct benzoin. The tapes consist of a micropore-like material which we place over the incised wound, and then we pull on both sides. Primary closure like situation can be achieved in these. These are the references: Atlas of Suturing Techniques by Jonathan Cantor, ebook version 1.0. Then Bailey and Love, Short Practice of Surgery 28th edition, and certain images taken from medscape.com. Thank you for your patience. I hope we get to take home certain tips and pearls from this presentation. Thank you again.